Happy holidays and welcome back to the Foam Frat podcast. We have an interesting episode today. I was messing around and Sam, do you know what Substack is? Have you ever heard of
Yeah.
Substack? Yeah, I was in Substack because there's a couple people I follow in there, and I came across PulmCCM, which I've seen on like X and on social media posting different articles. And I went and I subscribed to it. And it was, I can't remember how much I pay a month for it, but it was really
It's
good
cheap.
articles. And it was more geared towards like if you were an intensivist working in the ICU. But I always like that stuff because I feel like, leaning and understanding a little bit more out of like your category can sometimes help put like the whole clinical picture together. And so I subscribed, and then I got an email from the Palm CCM editor, and I'm like, uh-oh, what is this? And he said, hey, Tyler, I saw you subscribed. I saw Foam Frat. Maybe there's an opportunity for some collaboration. So he actually like reached out, and it wasn't like an automated email. It was like a legit email. So I thought that was super cool. Made me even more happy that I had subscribed. And so we started to discuss what we could talk about. And I've always been interested in how the things that we do in the pre-hospital side influence the patient's care in the ICU. And, I imagine in my head, this probably doesn't happen, but, there's a bunch of intensivists sitting around the water cooler or something in the break room having coffee. And they're like, God, I wish paramedics would just blah, blah, blah. Or, man, I wish they would stop doing this. And we talk about it a little bit in the episode, but it's like the plumber coming in and then the electrician coming in, and nobody's really talking to each other, but everybody's irritated about something. And what I found was that this was not even close to the reality of the situation. And so I kind of prefaced it a little bit like that with you. But I was like, all right, when you listen to this, it's going to be a little different. And so I was curious, the way he answered the question. And even towards the end, I was like, all right, quit being politically correct, rub my nose in it. What are we doing wrong? And it was interesting. What was your take on it?
He speaks in a lot of generalities, and that is not that's not throwing shade or anything like that. I think that the reason was because the questions were more general as well, and that tells me that he's seen a lot and he's experienced, and he really appreciates the nuance and probably knows a lot. I mean, looking at his website, I mean, he's written pretty extensively on a lot of the topics, and I know that he could speak very deeply if he wanted to. But it made me think of two things. And it kind of had to do with the way that we think about some of these topics, and we go really deep on them, And it's when you start diving into a topic, it's like the more you know, the less you're worried about, with a big asterisk that's not right away. Like when you start diving into a topic, everything seems super important and it's overwhelming. And then you learn that it's more so like the fringe cases, but you have to learn the initial stuff first and kind of be overwhelmed. And then you start to filter through those things. Like when you start to learn ECGs, you learn the absolute basics. And then if you go to Dr. Smith's ECG blog, which is an awesome website, but it kind of makes you feel like if you don't know every single one of these little things, that your inability to recognize these super nuanced things on an ECG is going to like totally kill your patient on the next call that you have. But you have to understand a lot to understand what you have to filter out. And that's like one of my favorite quotes is that like chance favors the prepared mind. And I think about it kind of like a bell curve where you guys are talking about like what a reasonable clinician would do and kind of like the averages and some protocols that are pretty like run of the mill stuff. Like for these patients, yeah, most of them are going to go on 6 to 8 cc's per kilo of ideal body weight. And he's like extra points if you have a chart that tells you that and stuff. But it's not until you get to some of those fringe cases that somebody's even going to care or they're going to notice. But it's those low occurrence things that happen on the fringe where if you can recognize it because of the depth of understanding that you have the opportunity to make the difference. But you have to know what to look for in order to find those opportunities. So I think just in general, when you have generalized scenarios and you have somebody that's like, well, most of the time that we're going to do this without the specifics, they're kind of going to give you a generalized answer. And I think that kind of feeds into the second thing that it made me think of, which is that EMS is special in that you do have the ability to recognize those things, and you have this microscope that you get to look at the patient with, and notice these nuanced things. Whereas most of the time, the vast majority of your care kind of falls in the middle of that bell curve. And it is just reasonable things that a reasonable clinician would do in a reasonable circumstance. But when you get to the fringe and there's 2 or 3 of you that are like really thinking about this patient deeply for minutes or hours, you can afford to put your microscope on that patient and think about the things that are within your span of control, because there's just such a large difference between the things that an intensivist thinks about, because they have the whole hospital at their disposal, and there's such a huge difference between what you can do during transport, picking the patient up, transport, dropping the patient off. There's a huge scope difference there between what an entire hospital and hospital staff can do and what you can do during transport. So I think it makes sense for EMS to really dig into the nuanced things that are within their scope and to be on the lookout for those fringe cases. But for the most part, like a lot of that patient care kind of falls into the middle of that bell curve where, and I don't want to say it in like it's not to say it in a nasty way or anything, but nobody's going to care and nobody's going to notice either, unless you have the depth of that understanding to recognize some of the fringe cases and be able to filter through that really sometimes faint signal through a ton of noise that you're getting, especially on some of those like ICU level transports.
Yeah, and it's more interesting if you're in like the FOMED world or you're in the world of content to make it seem like, oh my God, if you don't clamp your tube, oh, you haven't been clamping your tube. Like if you get real nuanced and black and white about, oh, you're not doing cuff prep. Oh my God, and it makes people like, oh crap, like I'm not doing that. Oh man. And while those things are all good, I do appreciate, like you said, when somebody is not so polarized. They're like, yeah, maybe it makes, let's look at what the evidence says. And he said something in the beginning of that podcast where he was like basically saying, you and I will never see the amount of patients to adequately answer that question. We have to look at the literature. We have to see what these larger studies show, because while it may be interesting and it may be fun to get really picky about little things and, oh my God, you're still doing this. And that's what makes people click on stuff. An expert knows when and where to put their bandwidth in something, and not to be dystopic and make it sound like, the majority of things don't matter. But I can remember being a national registry proctor or examiner or whatever for the test. And the case was, and this is when they had to start doing those longer cases. It was a guy who burnt his hand, right? And so, the paramedic student with all this knowledge that they're trying to obtain and to try to synthesize and put into action. And he calculates the burn percentage for the hand. And, what do they say? The hand is roughly like what, 1% or whatever of the patient. And then he tries to calculate the Parkland formula for 1%. And then he's trying to figure out how he's going to give half of that over. And watching the bandwidth, and if you were to just ask anyone walking by, what do you think that this patient needs? It would be like pain management. They're not hypovolemic. They're not hypotensive right now. But their bandwidth was like, I have all these things I have to do. I mean, I remember, when you do the alcohol prep before an IV, you have to go in a circular motion, just the things that you were like, they're going to count. This is going to take points off if I don't do it this way. And then you talk to somebody who's been around the block and they've been doing this for a while, and they see how these things go, and they don't get so, I'll take a term from our friend Dan Rao. They don't get so wrapped around the axle about certain, specific things. And I can appreciate that. And so that's what I think this episode kind of brings to the table is, no, they're probably not all sitting around, the coffee break room talking about things that the paramedics do that drive them nuts. But it is cool. And I do think the more we can bridge those specialties together and talk about things, the better we can get that completed picture of patient care.
Yeah, and I think that's maybe one of the most important points is looking at other people's kind of signal to noise ratio and seeing what gets them, wrapped around the axle or whatever. And when you start comparing a lot of different specialties, you start to understand like what actually takes precedence in the limited amount of time that you have with patients. And maybe the side point of that is sometimes clickbait is clickbait. When people get really, really wrapped up about something, sometimes your time is spent better understanding the whole of the process, and that helps you filter out what's important and what isn't.
Awesome. Well, happy Thanksgiving from the Foam Frat team, and check out PulmCCM.org, and we'll roll the episode. So I made a list. I got a list of some of the questions that I had, and then I also reached out to some of the flight clinicians that I work with at LifeLink 3. And so I thought we could start off with the first one: is, do endotracheal tubes placed in the field make the patient more vulnerable to things like ventilator-associated pneumonia, as well as like other complications? So what have you seen? And I don't even know if you always see those patients, because they probably get filtered through the ED. Do they exchange that in the ED and then come up to the ICU? What's your thoughts on that?
Right. Yeah. So most of our experiences, the patients have come through the ED first, and then there's, like you say, a filtering process, and then we would get them afterwards. Usually where we're receiving them in the ICU is direct ICU to ICU transfers. So there is some of that, but those folks have been obviously already cared for in the ICU. But what I would say is that I've also worked in ERs, though, as an internal medicine doctor in the VA system. And what I would say is, we can't rely on our own experience to really answer that question. And fortunately, there's been these large case series and a few randomized trials, and they still leave a lot of room for debate as to specifically the question of ventilator-associated pneumonia. There's some suggestion that in case series that the tougher conditions of intubating in the field lead to more aspiration and more ventilator-associated pneumonia. But the biggest two studies that I have seen were in traumatic brain injured patients, and they both suggested that there really wasn't that much of an increase in ventilator-associated pneumonia in that population of patients, in TBI patients. So that specifically was, I guess, somewhat reassuring for that particular issue. But I think and this is where, I don't know how much your audience is going to like that what I have to say here, but I mean, the real question becomes, what are the complication rates overall of intubation in the field versus in the ER? And that gets much more fraught and problematic in terms of basically just the complication rates from intubation in the field are much, much higher. The immediate complication rates, not the downstream like ventilator-associated pneumonia, but just immediate complication rates appear to be much higher than intubation in the emergency department or the ICU. And that looks like it's been pretty well replicated in multiple well-done series. And so that could trigger off a deeper discussion about, when do you intubate and when is it better to use a supraglottic airway or just bag mask the patient as opposed to intubating. So I guess I would turn it on you and say, what are the indications to intubate a patient in the field versus using some other not as advanced airway to get them to the ED?
Yeah, that's a great question. So in my experience, I hate the iGel. I hate supraglottic airways. They are a pain to try to ventilate with the Hamilton T1 or any ventilator. It's not just a T1 problem. It's any ventilator. So if I come in and I got a patient, say we jump in the back of the ambulance, I got a patient who was in a motorcycle accident. They're unresponsive. Maybe they've got a report of vomiting at least once. That's a pretty easy tube in my experience. You're going to go in, you're going to resuscitate, oxygenate, you got your suction, and you get the airway on them. And I'd much rather take them into a trauma room with an ET tube because I can effectively ventilate them better. And I don't have any data really, maybe a little bit of data. There was some studies that came out of patients who came to the University of Minnesota to get put on ECMO. They found they met their gas markers because when they come in for ECMO, they do an ABG and they want to make sure that they have, decent PO2, lactate, CO2, etc. And they found the patients who came in with a supraglottic airway did not meet those requirements as much as patients who were intubated. Now, where it gets a little tricky is the patient that is unresponsive, but they're breathing fine. It's not like it's not like they're vomiting. And you'll hear, well, they couldn't protect their airway, so that's why we intubated them. Or, hey, they had a GCS less than 8, so that's why we intubated them. And I have a hard time buying into that, because if I have a patient who is a trauma patient, they're hypotensive, and the only reason I would intubate them is just because they're unresponsive, whether that be from, just hypovolemia, they're not perfusing their brain adequately. I can sit there beside them with a end-tidal CO2 cannula on, measuring their CO2 with suction, and I look at those patients as like negative pressure breathing is like the best pressor that they could have, and I have no problem with that. But as soon as you start throwing in like, oh, I think they threw up, or they start seizing, like there's obviously things that make you lean more towards intubation. But I would say that the number one risk, I think, that you see in the EMS setting or the critical care setting is aspiration. I mean, you're going in with patients who have not fasted. They just ate wings and have beer in their stomach. And so that's probably the most likely, or the most I would say the most likely negative effect, or the adverse thing that could happen, is that they actually aspirate something, because that's not good. And they're not fasted. But other than that, there's talk sometimes when we do these airway labs of, oh, you got to be careful not to touch the end of the ET tube, because if your gloves touch that, you could introduce infection. And I'm always like, I wonder how often that's actually an issue in this patient. Like you touch the tip, like with a Murphy's eye, or you grab it and you're lubing it up, and, oh, you got to be careful. You can't touch that. You got to keep that part in the package. That seems more like a problem that we're inventing that probably isn't as common as something like aspiration.
Yeah, I agree with that. And let me, by the way, I had a note here that I have to read a little disclaimer that I forgot to read. So I'll just throw in quickly and say that everything I say here today are only my opinions, have nothing to do. I'm not speaking on the behalf of any employer. And that I'm a practicing community intensivist, not affiliated with any academic medical center, don't have any special subject matter expertise. These are all my personal opinions and don't constitute medical advice or professional advice to paramedics or anyone else. But Tyler, I think you touched on the key things, which are, as I see them, which are, basically use your head, use your critical thinking skills, and evaluate the situation and try to do what's called for while weighing the relative risks. And there, to your point, I think there actually is some fairly good data out of Australia, and I wasn't aware of the Minnesota paper, but for trauma patients, like you said, if they're severely traumatically injured, comatose, at this one center in Australia, they did significantly better if they were intubated in the field. But I think what that ties into, and what we're both kind of getting at, is it all loops back to, how replicable are any of these studies? How applicable are they to you personally, to any individual person doing this or watching this personally? Because it all comes down to what is your personal skill level. I mean, if somebody is there, I have no doubt that they're 100% certain that there are many EMTs who can intubate better than certain intensivists, and or ER docs, or take your pick. Anesthesiologists, they're pretty darn good. Yeah. But no question in my mind that is a real thing, and so it comes down to, if you're really, really good, you're probably going to have a low complication rate. And if you're not and I say good, that's a loaded term. It's really all about experience and practice and reps. And that's where, like I say, it gets fraught. And I feel like my little role here might be to put a little bit of doubt, I guess, in certain people's minds, speaking from my own experience, which is that it's very easy to be overconfident about your intubation skills. When you go and look at people Intubation. I don't play much golf anymore. I never really did play much, but it's a lot like a golf swing where at first you suck terribly. Then after a certain amount, you get to where you can decently hit it. And every once in a while, you hit it amazing, but you don't hit it amazing every time. And sometimes you really whiff, but it feels like you're pretty good at it. I think intubation is a lot like that, where, and I think there's data to back it up, where folks who aren't as good as, or, skilled or experienced as they need to be to really get it every time without complications, nevertheless still have a high confidence in their skills. And so I think overconfidence is an issue. And I say, speaking from experience, where I came out of fellowship and I thought I had done, I don't know, 50 or 100 intubations or something. And I thought I, was whatever you want to say, call it. But I thought I was really good at it. And looking back, I just wasn't. It took another, whatever it's been. I've been doing this. So I got finished fellowship in the mid 2010s. And so, every time I feel now I feel like I'm more consistent. But anyway, that's the biggest risk, I think, is overconfidence and having even just the experience of taking multiple attempts, even that is associated with worse complications downstream. And that's the one thing that I would just I would go back to myself and put a little grain of doubt in my mind as to how good and experienced I was and how much more practice I needed before I was going to be doing it completely independently on all patients.
Yeah, there's very predictable things that people do that make them fail, right? It's not always the skill of putting the blade in and engaging the hyopoglottic ligament and delivering the tube. There's things like not having suction available, not pre-oxygenating appropriately, trying to intubate somebody who's hypotensive. Like, there's certain variables for sure that you can predict, you can create checklists for, you can get in the habit of, practicing in that way every single time. But then, like you said, there's also just the actual skill of, are you shoving that laryngoscope down and just trying to find something? Are you incrementally working your way down the tongue? So no, I think those are all really good points. And I was just curious if you see more adverse effects, or if that's not even a thought process. It's like, oh, I bet paramedics did this tube. It always has this, this, and this. So that's what I wanted to see, if there was anything that you specifically noticed, or if there was something that you wish you would see more often that EMS does that just grinds your gears.
There's really not. And, the EMTs are, they're just a blessing to the world and the medical system. It's a pretty underappreciated and unsung job where, like I say, I worked in some ERs before, and once I had worked in an ER, I realized just how spoiled, if you want to use that word, that we are upstairs, so to speak, in the ICU, where these people were just on their couch, an hour ago. And when you guys get them, they're on their couch. And so there's a certain amount of just, I guess, respect that goes with anyone when you can just walk in and manage that situation. And you need to do what you need to do, and you guys are trained to do that. When we get the patients, they're virtually always, in my experience, they're virtually always just stabilized as best as the patient can be. And no, I've never once now I'm not working in ERs all the time. So, you could, I'm sure, find an ER doctor who'll talk some trash, I guess, but I've never once gotten a patient and said, and for that matter, I've never gotten a patient upstairs from the ER where the note, if there's something that wasn't right when they showed up, the ER doctors got some risk there themselves. And so they're going to have to actually paper that over in the chart, so to speak. Well, when I got the patient, there was this present on admission, so to speak, so that wasn't my complication. I hate to say that that's how medicine has to be practiced sometimes, but it is. And you know what? I can't think of one case where I've seen that, where they threw the EMT under the bus or whatever, because it just doesn't happen that much. You guys nail it and bring the patient into where the advanced care can be provided, and then it gets taken from there. So I can't think of one specific thing. Like I say, other than and
How
the truth is,
how often are you getting patients coming into the ICU from like a flight team or from a critical care ambulance team? They're coming to your ICU and you're actually seeing them bring the patient in and get admitted to your ICU.
weekly. A lot of times those are stroke patients, or they're septic patients who but they they didn't come right off of the from their house, or obviously from an air flight patient, but they're folks who got brought into a very rural center, and then within a couple hours we've got them. And so we have, we're seeing those fairly often.
Yeah, my question with that is, we'll go into a small rural facility. Sometimes they'll be bagging the patient because they're just not comfortable with their ventilator. Sometimes they will be on a ventilator, and we'll go in, and there's some providers who will just copy the settings as they see them and put them on the vent, right? And that's because, well, if the hospital has it, this must be the best vent settings possible for the patient. And then there's another, I would say, kind of thought process that when you come in, we need to be the patient's first exposure to critical care, where we're actually doing things like looking at ideal body weight, making sure that, the IDE times are appropriate. Sometimes you walk in and you're like, okay, we got 25 a PEEP, but we have a inspiratory time of 0.3 seconds. Let's come down on the PEEP and try to increase our time a little bit. And so we'll start to finesse those ventilator settings for that patient to optimize them, because it's very likely they're put on crash vent settings because they just wanted to get them on the vent, and they haven't actually had the time to calculate the ideal body weight tidal volumes and finesse the I times and the PEEP and figure out what they need. And so we'll set that ventilator up and we'll get it perfect in transport. And we'll sit there and titrate little things. We'll make sure that we bring that ventilator to what the patient needs. And then we hand that over to the hospital. And I always wonder, like, if I didn't do that, if I just put them on the most vanilla, like 500 tidal volume, 100% FiO2, would they stay on that? How long when EMS brings you a patient, do you walk in and go, ooh, those are not good vent settings? Or is it, if it's working, just keep it going? What's your thoughts on that?
Yeah, so most hospitals now, really all hospitals that I've worked in the last several years, have created ventilator protocols. And so as soon as a patient comes in, the ventilator protocol settings are going to be activated. And in most cases, that's all. It's going to override everything that came before, and most times that's going to include a low tidal volume setting and their a PEEP range and everything else. So I would say, again, I don't have experience. I'm sure it's happened where I say, oh, look at these crazy vent settings, because how crazy are you going to get? I mean, like you say, they're going to be kind of usually they're going to be kind of in the middle of the road. And it's fine, I mean, it's a short period of time, hopefully, that the patient is en route. And I would say, out of all the things you could do, better or worse, the biggest thing to avoid would be to have them on crazy high tidal volumes. 6 to 8 milliliters per kilogram of ideal body weight is completely reasonable. I would think most guidelines would agree with that. So if it's, you could, for extra credit, I guess you could have a card with the height of the patient mapped to the tidal volumes. But generally speaking, for women, 350 to 400, for men, more like 400 to 450. And 500 is probably okay for patients who are not super short. But again, important thing at the beginning is making sure they're oxygenated and ventilated and getting them. It's a short period of time, so it seems like a relatively low risk period as far as the vent settings. And I've never seen anyone come in on PEEP of 25. That's a lot, but the truth of the matter is you don't have an X-ray on these patients, and this is sort of the pitfalls of me getting into these kind of conversations. I guess is you don't even have an X-ray. You don't necessarily know the cause of their respiratory failure. So an intensivist shouldn't be telling you what to do in those situations, other than, I would say just to not use. And I don't ever see, like I say, ventilator settings that seem tremendously out of bounds. So, do you have guidelines where they say here's what you should do for the generic patient who you have no idea why? I mean, you have some idea, but you don't have any diagnostics as to why they're in respiratory failure.
Yeah. A good question.
Does it tell you? Do you have guidance from the authorities, or so to speak?
Yeah, so we try to do everything as evidence-based as possible. So if I got a patient who is, they came in with respiratory distress, they have some infiltrations on maybe their right side, left side, whatever, and they're having a hard time oxygenating the patient, right? So my typical strategy with that is I'll figure out what their height is, figure out, like you said, 6 to 8 cc's per kilo, put them on, get them ventilating, put them on 5, 10 of PEEP, get the FiO2 up, start titrating that. And then I start looking at, okay, if 10 of PEEP and 100% FiO2 is not increasing their sats right now, and I typically do have a chest x-ray if I'm doing an interfacility transport, because the rural hospitals are pretty good at getting that. I'll look at it and be like, something's weird about this, And so because the air needs time to penduluff through the lungs, I'm a big fan of eye time over just going up on PEEP. And I think there's a thought process that FiO2 and PEEP are the only way to increase the oxygenation. And time is actually one of the best things to do, because, you look at these lungs and you see it go pop, 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 pop. It all starts to open up. It needs time to get through there. So what I'll do is I'll get to like 10 of PEEP, and then I'll start increasing my eye time, because typically on sick lung patients, it's not like you're air trapping. They have time to get back to their baseline and their flow waveform. And so that's my strategies. I'll start going up on the eye time, get the PEEP to where I think it's manageable. I'm, increasing the mean airway pressure, but you get more bang for your buck, I find, increasing the eye time as opposed to going up to 25 of PEEP. And then once I get them in that range where I feel like they're oxygenating well, and during COVID, we kind of saw some of this, is once you start inversing your IDE ratio, it essentially leads itself to APRV in some cases. And so, we don't find ourselves implementing APRV as much, but it definitely is within our guidelines. It's an option. We can continue a patient on APRV, but there's benefits to that. And there's also things that are not as good. Like you want them to kind of be breathing on top of that to get the benefits of APRV. But I think that's probably a whole another discussion. But we do have general guidelines. We try to keep our pressures here, keep our ideal body weight, tidal volumes less than, 8 cc's per kilo or so. But then there's the things that we titrate because it's actually something wrong with the patient, like an asthmatic who comes in and they're air trapping. We have a strategy for that. The oxygenation patient, we have a strategy for that. The motorcycle accident who's just intubated because he was throwing up and, has a traumatic brain injury, that's probably going to fall more in that like generic setting.
Yeah, going back to just tailor your thought process and the treatment to the patient. Like you see, you're talking about increased eye times, and then with the which I don't have any strong opinion about that either way. I don't have any data to say that that's that works or doesn't. But certainly with the asthma patient, like you say, you're going to increase the expiratory time probably on that patient, and then most of the time, though, just circling back to what I said at the top is if we're talking about an hour and you've got the patient on vent settings that are reasonable, and no, I would not do 25 of PEEP. I can't remember ever doing that. But in the range of somewhere between 5 and 10 or 15, I guess at the top end. If someone is in ARDS, sure, you might be on the top end of their PEEP, but otherwise, yeah, mainly minimizing ventilator-induced lung injury and and keeping their oxygenation up. And, transporting someone on FiO2 of 100%, if I don't think anybody, there's these theoretical risks of oxygen toxicity, but again, short period of time, and then you got to balance it against the potential risks of hypoxemia unrecognized during transport if there's some atelectasis that occurs or what have you. So all of those are reasonable parts of your thought process to me.
Awesome. No, the other thing that I had on here was some EMS providers like to use ketamine drips for sedation during transport. How often is this continued at the receiving hospital? Is there any downside or upside to EMS using ketamine in this way? We don't seem to see ketamine infusions in the ICU often. So why is that?
So yeah, ketamine is kind of the new kid on the block, sedation wise, and for a long time there, it was just used almost vanishingly rarely, and now I've seen it more. It's very system dependent, where honestly, what it looks like to me is that XYZ ICU, because I've worked at as a locum doctor for different hospitals in different parts of the country, and at XYZ hospital, the medical director thinks ketamine is great. And then guess what? Ketamine is used as a continuous infusion for sedation on not necessarily every patient, but 25% of the patients, say. And I actually see some benefits. I see some potential benefits to that, in the sense of some of these folks we've got on fentanyl drips for weeks. We pretty much give them all some kind of opioid dependence, and obviously we all know that's not a great thing to have as a result. And so with ketamine, theoretically, you're avoiding some of that. But there's also very little long-term or longitudinal data on what ketamine might produce over days or weeks of continuous infusion. So by far my experience has been that it's not used, that it's used like as a third line agent after fentanyl and propofol and Precedex, so maybe fourth line. And a lot of times it's a patient who has a psychiatric history or is really agitated, and then ketamine is added as an adjunct to try to keep control of the situation. I don't know the costs, but I have some sense that it might be more expensive or just not regularly sourced, because there's often a pushback by pharmacy at some places to not use it. So very system dependent.
Yeah, if somebody came in on a ketamine drip, if I brought you a patient that I put on a ketamine drip because they were hypotensive, and I was like, this probably isn't a patient I want to put on propofol, would you, this is a tricky question, or not tricky, but this is something that's been a controversial topic. Would you put a patient on propofol and then put them on Levophed to counteract the vasodilatory effects you get from propofol? Or would you rather put them on something that is not as likely to cause hypotension, like ketamine? Or do you feel like it's completely fine to have propofol and Levophed on a patient who was hypotensive?
Yeah, it's hard to speak in general, or in terms that would cover all those situations, because it's so patient specific. Like I say, although we know propofol causes hypotension, and probably more so than fentanyl, I think we would be more likely to switch them from propofol to fentanyl. That has been my experience. And then if patients can't be controlled with fentanyl, yeah, generally they in a lot of places they do go on propofol, and if they have low pressure, they get put on vasopressors. The fact is, most of those patients, it's in my experience, it's just hard to tell how much of the hypotension is being directly caused by the propofol. It's usually a patient who's already got some hypotension, and so you're really already in a situation of using suppressors, and then you might titrate them up when the propofol is added or increased. There's other patients where you add propofol and their pressure seems to bottom out, and you stop the propofol, and figure something else out, and that might be the patient who's considered for ketamine, for example. But it's all so fluid and so multifactorial. It's hard to speak in terms of, heuristics or general rules that we would use other than just, trying to hold up, keep the wheels on until they get better, basically.
Yeah, a typical scenario for us, we go in, somebody's septic, they got intubated, they're under sedated at the time when we get there, and so maybe they've just been given midazolam pushes. They haven't given anything for pain. Like, this is just a very common type situation. And so we look, the blood pressure is maybe MAP is 56, 60. They're on a Levophed infusion. And we're like, we got to do something for the sedation, right? So I could either, obviously I'm going to probably just intrinsically give them 100 mics of fentanyl, just average adult, just to try to get ahead of the pain, address the analgesia side of it. But then there's well, I don't want to keep just pushing midazolam. I like propofol. So if I start propofol on a patient who's already on a pressor for hypotension, should I feel guilty about that and being like, you know what, I just probably have to go up a little bit on my Levophed, but that'll counteract the propofol? Or is that a patient where you would be like, no, do not give propofol on that? Or would you say try it? If they bottom out, then just take it off? I like that approach, but I just wonder what your thoughts are on that scenario, because it's very common.
Well, it goes back to what I was saying earlier, where you have a tough job. I mean, that's putting you in a position where you're the tip of the spear, as my special forces friend used to say, where you're out there right on the edge. You've got responsibility for this person, and you have excellent skills and excellent training, but it's that in your scope of practice, and you haven't done a critical care fellowship. It's not, and not that to say that doing a critical care fellowship gives you some magic power to know exactly what to do either, but it's sort of what's being asked of you, in a sense. Like, you're being asked to practice critical care, and so it's tough for me to say, what you should do. Other than, I mean, if you're at another center, I would grab it, whatever MD was there, and see if they have any thoughts. And I mean, you've probably got your own sense of how skilled they are or knowledgeable they are.
Yeah, that's the thing, dude, is I feel in these situations, and I know, you got to give the politically correct, most generalizable answer. But in reality, dude, I'm wanting to know, when you walked in, because people know not to take what we say on this podcast and say, oh, I heard it from Tyler and Matt Hoffman on this podcast, right? They know that we're getting down to the logistics of it. What you walk in, you see this and this. Obviously, you could be like, well, I got to look at their labs. I have to look at this. I have to look at that. But, there is a sense of, I got to make these decisions pretty quick. I need to get rolling. I need to get them going towards the ICU. And so that's why I was curious, because we do have a very good group of core medical directors where I fly, that we have intensivists and we have ER docs, and we could call them and be like, hey, I got this patient, they're hypotensive and they are not sedated well. I gave them 100 mics of fentanyl. They're on 0.2 mics per kilo per minute of Levophed. What are your thoughts on me putting them on propofol and bumping the Levophed up? I'm guessing we're not going to need as much propofol because they're in a shock-like state, so you're going to get higher brain levels at a lower dose. 20, 30 mics per kilo per minute, up the Levophed to 0.3 mics per kilo per minute and see how they do. They've already gotten 2 liters of fluid. Then I feel like most people will be like, yeah, try it out. see if that works well. If it doesn't, try something else.
Yeah, I mean, the issue with applying the experience across is the question is, does what I do, or what I would do in that situation in the ICU, does that translate to a clinical situation that's fairly different? I mean, you're stabilizing a patient for transport, and they haven't gotten that initial care. You know what I'm saying? You're in a totally different situation where you're trying to get them to the ICU, at which point that's kind of where all of my personal experience as far as knowing what to do has already taken place. But, if I've got a patient who's already been transported, and And we're running into that problem in the ICU. In other words, they're under sedated. Maybe they're having some ventilator dysynchrony, some hypoxemia, and they're already on some Levophed, and the fentanyl is just not cutting it. Yeah, I mean, we've got to add another agent, and usually that's going to be in that setting. I mean, I might try Precedex first, depending on the degree of agitation. Sometimes you have a sense that Precedex isn't going to cut it, and yeah, you have to use the propofol, and you're going to have to go from 0.2 to 0.3. Or add vasopressin. So that's a real situation that happens in the ICU where, again, relative risks and just managing the situation, a tough situation the best you can, and you've got to make tough choices.
Yeah, and I appreciate, you, and I've talked to, are you familiar with Josh Farkas from Vermont,
yeah.
Dr. Farkas?
Yeah, he's amazing.
Yeah, and I had him on the podcast a while back, and we were talking about approaching the shocky patient who's an AFib, RVR, and you're trying to figure out, like, at what point are you going to control the rate? Is the rate causing the hypotension? Is the hypotension causing the rate? And he's like, he prefaced it with, I got to be honest, like, I am seeing a different type of like scenario than the ER docs are. My patients in the ICU are looking like this. And my thought process is like, I totally get that. Like, that makes sense that they're coming in the ICU, a different phase in their care. But I find that talking to the people in different specialties, the RTs, the nurses, the crit care palm docs, the ER docs, it's almost like, when they're building a house and the electricians come in and then the plumbers come in and then you got the people who come in and do the drywall, and they're all like never talking to each other, but they all like, oh my God, who did this? I wish they would stop doing this. And while they are all taking care of or building the house in a different phase, there is a lot of benefit to saying, like, we were talking about the Thiazem, and I was like, yeah, if you're given, or I'm sorry, amiodarone, I was like, are you giving that 150 over 10 minutes, like putting it in a bag and letting it run? And he's like, no. He's like, we push amiodarone, like just a slow IV push. And it's just hearing different things, and the way people think through different situations is very valuable when you're trying to put together a clinical picture, specifically for EMS, because there's a lot of pieces of the puzzle that we never see.
Right.
We drop them off. You guys say, great job. You guys have a hard job. We know you're, and it's like, okay, yeah, it's hard, blah, blah, blah. But did I do the right damn thing for the patient? Or what are you going to change? And I always say, if I get to the hospital and they do something within 10 minutes of me dropping that patient off, I probably should have done that thing to the patient. And so that's where I find like it's beneficial to have these conversations and see what would be Dr. Hoffman's practice and what would be Dr. Farkas's practice, and then what would the ER docs be, and then trying to look at it all, because there's always the right thing for the patient, right? The patient always needs something, and the atmosphere often will change what they get or how you approach it, but you're kind of the end of the road. Like at the end of the ICU, they either go home or they don't, And so that's why I feel like I can learn a ton from like the critical care folks and seeing, because you're seeing them come in sick and then hopefully leaving better or better than they were when they came in. And that's the area that I have the most interest in right now, is trying to figure out what are the things you're doing. Are you monitoring cuff pressures, like crazy? Are you always watching those cuff pressures and keeping them below this? Or, what does that look like? So I apologize for like trying to keep grilling you on it, but that's where I am most interested in, is your mindset with it.
Yeah, well, what I've long thought that we all would benefit. I mean, I think it would be, I think it just would be tremendous for everyone if we could do like an exchange student thing where we would ride along on each other's jobs. I just think that would be so massively beneficial. I guess it'd be massively expensive in terms of taking resources away from where people are working full time and whatever. But even just once a year, like to ride along on with you guys, and vice versa, you rotating through the ICU. I think it would just be a tremendous knowledge transfer, and also just build the unity that we really already have, but don't recognize that we're all working together on a team. But, I know you maybe you think I'm being politically correct, but the truth is it just doesn't ever happen, not in my experience, that Farkas works in Josh works in the ICUs too. You could get Scott Weingart, who's the EM crit guy, M crit guy, who's like amazing. He's just genius level in terms of his breadth of knowledge and experience in the ER setting, and he's basically an intensivist in terms of his knowledge base and skills at this point. He could, maybe give you some more, talk some more smack about things that he's seen. But you guys have the patient for such a short period of time and virtually always do the reasonable thing. And then, you hand it off. And here's another thing I'll say about that is, who's to say that when the critical care doc gets the patient and they change something, who's to say that they're making a better decision than you were? I mean, sometimes maybe, but sometimes it's just, hey, that's what was in the protocol. They're just clicking a couple boxes and the patient gets switched from this sedative to that one. There's a lot of that. I have over the years come to be very humble as to the sphere of my powers and influence. I'm proud of what I do. We do help save lives and help people get through extreme illness. And there are certainly some times where my recognition of situations and my personal decisions have led to that. And that's awesome and an awesome responsibility, really. But there's been many, many more times where I did the same thing you do, which is do something reasonable and put them on kind of middle of the road settings of whatever, and medications and the vent and antibiotics and steroids and diuretics. And you know what? It's out of our hands. The healing processes are unfathomably complex and operate outside of our control for the most part, or understanding even. And so really all we're doing is life support, supportive care, and buying time. And yeah, some other important stuff too. I mean, let's keep looking for every single thing that we can do around the edges, and occasionally, crucially and critically, that can make the difference to help someone get better. But a lot of times it's just, keeping them going until their body heals up on its own.
No, this is great, man. I know our 15-minute discussion turned into a 45-minute discussion, but I think people will really appreciate that. And it's always interesting when you talk to somebody who is, in a profession, and you hear the things that get their brain going more, and then the things that they're like, yeah, put them on this vent setting. Yeah, maybe we'll do this if I have sedation. And it always seems like there's certain things that are like where you want most of your bandwidth to go. And there's other things that I think people tend to let their bandwidth not dive into as much, because there's RT, there's protocols at the hospital. And so you're probably doing a ton of this higher level thinking. What type of antibiotics should we be doing? What is, trying to do a bronch? How do we get them out of the hospital? And then you have things like protocols, and you have people and specialized teams within the hospital that can focus on other stuff. And I remember getting done with paramedic school and being like, okay, they have left pathological access deviation with the new right bundle branch block. And then I'd go and talk to the doc, and they'd be like, yeah, we'll trend their troponin and see what happens. And I'd be like, so did I just waste too much bandwidth on that topic as opposed to this topic? And there's no right or wrong probably, but it's the things that are more like, if I say, yeah, the patient's glucose was 230, and, my partner repeats it and they're like, yeah, it was 250. That doesn't really matter. Like, there's certain things that just don't really play that much of effect into the long-term outcome. And so that's what I wanted to see with you, is like where your brain goes on some of these patients when they come in. So I really appreciate that a lot, Matt. And I appreciate you coming on. The last thing I wanted to ask you, and this is like, it can be a real quick point, is EMS is obsessed with clamping the tube when they transfer the patient from one vent to another, so that way they don't lose any PEEP. And I tend to think it probably doesn't matter as much, maybe if they're on a really high level of PEEP. But what is your thoughts on it?
I don't know. I don't know that that's been looked at. I don't know how you would. I guess you could look at it with, you could look at it empirically with before, after, case controls, do it on these patients and don't do it on these, you would need an awful lot of patients and see if their oxygen levels dropped or not. I don't know that that's been done. You could do it with like nuclear medicine scanning and actually see what their experimentally and see what their
but it's not keeping you up at night.
No, I would, if you're doing it and it's working and nobody's getting hurt, keep doing it. And,
keep doing it.
I have to go back to what I said. I shouldn't be giving you guys advice. Sometimes I think it should be the other way around, but it sounds reasonable.
Awesome. Well, Dr. Hoffman, thank you so much for coming on. I look forward to it, furthering this discussion and talking in the future. If you guys want to check out PulmCCM, is it pulmccm.org? I got to look at it
That's
again.
Right. PulmCCM.org. .org, yeah. I think .com might work too, but .org is the actual domain. Mm-hmm.
And you're putting up, some of them may not be applicable to EMS flight clinicians, but I've seen quite a bit that actually are. And if you're a nerd and you're into some of this deeper stuff or what happens afterwards, definitely check it out. It seems like you update it every week, or is there something that comes out every couple days?
Yeah. So the website started as a newsletter back, 10, 15 years ago, 12 years ago, during fellowship, when I kind of realized that there's these 30 different journals publishing things, and there were, at that time, really wasn't anyone kind of bringing it all together into one feed. So that's the quick take on it. Is it's just a continually updated newsletter feed of the most hopefully the most recent and relevant, important research in critical care, touching on a lot of the stuff that kind of the things that we've talked about here. And there's a lot on there with mechanical ventilation and a good bit on resuscitation, that kind of thing. So there might be something for listeners and those watching to enjoy. But yeah, it's updated at least weekly. Usually there's 2 to 3 posts a week, and trying to stay on top of that fire hose that we're all trying to drink from. So of information.
Awesome. Well, Matt, thank you so much, and I appreciate it, man.
Thanks, Tyler. Talk to you again sometime later.